Rheummates podcast. This is a podcast about rheumatology, and it stars me, Jack, and my friend Mike, and we try to make sense of the complicated world of rheumatology and musculoskeletal practice. Hello everybody, welcome to the first episode of Rheummates. In this episode we discuss a very interesting paper about axial spondyloarthritis and the symptoms that might lead you to suspecting this and how to refer onwards. So we'll talk about that more in the show. I'm joined by Mike Dare, a rheumatology specialist physiotherapist, and we talk all about this paper. And we basically go off on tangents about axial spondyloarthritis and how best we might recognise it in clinic, and we try to make sense of the complexity. So I hope you enjoy the show. Please do go and check out my website, rheumatology.physio. You can subscribe to the podcast on Spotify, Android apps and iTunes. And you can also subscribe to my YouTube channel, where there are various other rheumatology resources as well to help you be the best clinician that you can with regards to musculoskeletal practice and recognising those pesky rheumatology conditions. Thanks a lot for tuning in, and I hope you enjoy the show. Shall I run us in with a bit of an introduction and then we'll just talk about things? Because I think I agree with you. I absolutely agree with you. There's a number of problems with this. One, it's way oversimplified. And two, it's only for AXPAR patients. It doesn't do anything for peripheral SPAR. It's not in peripheral SPAR. So, and also, what I was interested in, I don't know if you noticed this, but the freaking loads of the non-diagnosed people fit the MRI criteria.
Yeah. But I mean, there's all these kind of articles and retrospective reviews and investigative studies where they've done kind of whole spine and SIJ MR sequences with normal people, and they found a lot of people have kind of SIJ criteria that would fulfill the criteria for AXPAR. So I think there is a lot of kind of false positives, and a lot of the data's talking about MRIs only having around 75 to 80% sensitivity and specificity in these conditions. So that's obviously quite powerful, because that just really reinforces that a normal MRI doesn't exclude AXPAR, does it?
Exactly.
And a positive MRI doesn't confirm it either.
One day this is going to be easy, and they'll come up with a new scan, and it'll be like 100% SIJ, like 100% AXPAR and 100% not, and it'll be really easy.
Yeah, I mean, you see that kind of bone marrow edema and stuff a lot in postpartum women, don't you? And especially women who've had quite a few kids.
Yeah, and the other subset of patients as well that it's not someone I've ever worked with, but apparently you get it like unilateral in high load one-sided athletes, like long jumpers and high jumpers. So I don't think it's tons, but if they're elite athletes and that's what they do, then you see some of it there as well, because they jump off their left leg or whatever constantly. Then they really overload the left side and not the right side, so you can see some reactive inflammation there as well. So there's I think you're not going to see many of them, but it'd be interesting in elite sport to have that as a differential diagnosis as well.
Yeah, and maybe something even like a hurdle runner. I mean, I don't know if you run hurdles, do you often land on the same leg when you run hurdles? You probably find, if that is the case, that I think
it depends, doesn't it? Because they have different stride lengths, don't they, depending on how long their legs are. So some people will probably get to an odd number, and other people might get to an even number. I don't know. But definitely high jumpers, long jumpers, triple jumpers, definitely would overload one side.
Definitely, yeah. Interesting. I mean, there's a lot of points in the article that could be misleading. I think the emphasis on abnormal CRPs or elevated CRP, as well like we know so many of these patients have normal inflammatory markers. So for me, that, really CRP in axSpA is not really that useful at all. Like in rheumatoid, where your inflammatory markers are quite sensitive or kind of have a close relation to disease activity in most cases with rheumatoid. But in your axSpA, there's very often not a correlation. So although you use it when you calculating your BASDI or your ASAS score, it's not really that useful otherwise.
I think from my experience, it was like, oh, they've got a CRP of 95. That's probably useful.
Yeah.
Like sometimes you get them, don't you? They're like their inflammatory markers are so high, then you've got to attribute it. And then, but if they're ever like, I always said this to people, if it's like 20, you probably get a CRP of 20 if you stubbed your toe.
Yeah, I mean, I think it's very unusual to see very high inflammatory markers with axSpA anyway. So if you are getting CRPs, in the kind of 70 plus range, then you've either got a really outlying high disease activity, or there's something else going on there, and you need to look into that.
Yeah, sure. I don't know what your experience with the inflammatory bowel patients, Crohn's and colitis. I've seen a few patients where their CRPs and ESRs have been raised because they've come in and they're just not doing well with their gut as well. I think that's probably something to be considered.
Definitely, like those are the guys that are going to come in with like CRP of 200 when they're having serious flares of IBD, and you give them 120 intramuscular of depomedrone if they have arthritis as well, and then a week later their CRP is 5. So
yeah, for sure. Something else, just while we're talking about the demographics here, because like you said, the CRP, they didn't really have it very raised anyway. Their mean CRP was under 5, so no one really had it. What I was interested in was their HLA-B27 positivity rate. They had let me get the numbers right. They diagnosed 46 people with axSpA. They had 73 of them were HLA-B27, which was 22% of their population, which is a massive number. So this is bizarre that they managed to get this. I don't know where they pulled their patients from, but that's a really high percentage. Nearly a quarter of them were HLA-B27 positive, and they didn't diagnose anywhere near as many as that with axSpA.
Yeah, I mean, I would imagine that the sample size would have come from a significant amount of people from Northern Europe, isn't it? So the HLA-B27 gene has always been thought to be much more positive in like your Scandinavian countries and Northern European countries. So I think this study was specifically done in Germany, wasn't it? So I mean, it would be interesting to see what their kind of ethnicity and kind of historic origins of their sample sizes were, and kind of correlate that with the high HLA-B27 positivity.
Okay. Yes, that might answer that question then. Yeah, they just serial referred people with chronic back pain from orthopedics and GPs. So it's not like, I was wondering whether there was people already in rheumatology, so they were sort of a biased sample. But actually not. But then, like we were talking about, they did have quite a high rate of these sort of, in the people that weren't diagnosed, having inflammatory changes in their SIJs. And we know, HLA-B27 is also sort of positive. We said about bowel patients, didn't we? But also in peripheral SPA patients, it's not as high as in axSpA, but certainly increased. So I wonder if some people had sort of non-clinical inflammatory back, but had peripheral symptoms as well.
Yeah, definitely. I mean, this is the thing is, when it comes to spondyloarthritis, as you know, it's not simple like rheumatoid, where, you can look at someone's MCPs and look at someone's MTPs, and if they're not swollen and they're not tender and their CRP is normal, you can say with relative confidence that they don't have rheumatoid. But there's no recipe for spondyloarthritis. It can affect, as you know, peripheral, axial. It can be a monoarticular arthritis peripherally. It can be kind of polyarticular. It can be axial with a peripheral enthesitis only. It's a very complex spectrum of rheumatic disease. So I think the article and what they're suggesting really takes away a lot of the reasoning and thought process around that complexity. And there's so many spectrums, isn't there? So your B27 positive male is going to have much more textbook features and respond much better to NSAIDs, for example, and have that classical morning stiffness. But then maybe your B27 negative spondyloarthropathy that's got more peripheral symptoms might not have that response. I don't know what your thoughts are about that.
Yeah, definitely. I mean, my experience certainly is that the B27 negatives they're never as classic, and then also women just don't fit the pattern. Like I was saying I did a virtual consultation the other day with a lady and said, and she's been diagnosed with AXPAR. She had MRI positive, and the symptoms are all fine, but she developed over a very long period of time. And I just said to her, like, you can spot the men in the waiting room. You basically don't even need to assess them, because they come in, they look barn or stiff as hell, and they just, they've probably got psoriasis or something, and you can spot them in the waiting room. But women are so much more difficult to diagnose, and we know that they're more likely to be B27 negative as well. So they are more difficult. So I think, yeah, you're right. The complexity of it, and like you said, the variance is the thing, isn't it? Because they don't, like you said, with the rheumatoids, they sort of progress in similar fashions. They have similar patterns, but none of these guys do. It's just literally a shot in the dark at what symptoms they're going to turn up with, what their bloods are going to show, what their family history is like, what their sort of other condition history is like. It's all over the shop, and I think it shows it in the results of this study as well. They've got, I'm just looking at the table that they came up with, the demographics, and they're literally all over the place. Like they've got some with uveitis, some with inflammatory bowel disease, some with psoriasis, some with peripheral symptoms, some with arthritis. It's everywhere. Like it's not like you basically don't even really get that many clusters that you can work from. So like you said, I think anything that tries to simplify the recognition or the onward referral ends up being unhelpful, because you sort of have to be questioning everything, because like we said earlier as well, like if it's peripheral SPA, like their back pain's not going to be their worst issues. They're probably in with Achilles tendon problems or plantar fasciitis or something. And then, so then you're like, oh, well, their back pain isn't stiff for 30 minutes. Well, it's like, yeah, because their back's not their problem.
Yeah, exactly.
So I think it's an interesting paper in the things that they come up with, but whether it certainly for like you and me in sort of more primary care settings, whether it's actually useful for us in any way, I don't think it is really.
Yeah, I mean, and how often do we find that these patients can go through 3 or 4 months where they're absolutely fine, and then they have these massive flares, for 2 or 3 weeks where they're completely bedridden, and then they could go through another several months where they're fine. So you have to be very careful when you ask them questions that they hear what you're asking. Otherwise, you'll miss each other, because if you catch a patient who's on their 3rd month of having no issues, and you say, do you have any morning stiffness? They're going to say no, but 4 months ago they couldn't get out of bed, kind of thing. So I think we can't base our reasoning just on a few different points. I think the most pertinent thing or important thing is, if you've got someone who's young, under 40, that's having insidious onset of axial spine pain, especially if it's alternating buttock pain, and they have a couple of extra articular features that we think go hand in hand with spondyloarthritis, then it doesn't really matter about the rest. We should be in AXPAR in those cases. I mean, the stiffness and the NSAIDs are useful, but to say that if someone's stiff for less than 30 minutes and they don't respond to NSAIDs, they're unlikely to have AxSpA, I don't think that's true.
No, I agree. I think, especially like you said, if you take a narrow view of the snapshot that they arrive in clinic with, then you're going to miss loads of them. And I think I've learned my lessons over time that just someone with back pain, like even if you ignore those specifics, but then you add in bilateral Achilles tendinopathy or something, then actually it turns out quite often that they do have a spondylitis of some kind. Maybe it is peripheral. And then because as soon as you start digging, and you'll know this as well, like you'll get someone in and you're like, oh, I don't think they have spondylitis early doors. You get to the past medical history and suddenly they've got Crohn's, psoriasis, their dad had Crohn's, their brother's got Crohn's, and you're like, oh, hang on a minute, their symptoms don't reflect a spondylitis, but actually their past medical history is so strong. How on earth can I rule this out without sending to rheumatology? And that's the thing, isn't it? Where, especially where we know that people's diagnoses are taking so long and they're running through a number of different practitioners before they get diagnosed. We have to be referring those people where we can't rule it out. It's not like we're going, I really think you've got a spondylitis. It's I don't think I can rule out spondylitis, so I'm going to send you for more investigations.
Yeah, I agree. I mean, it's incredibly complex, and I think when you start adding in flavors like inflammatory bowel disease and psoriasis and the family history, it gets quite medical. A lot of these patients are going to be on like your Pentasa, mesalazine. They'll have courses of PRED when they have flares of IBD. They may be on methotrexate or anti-TNF for their psoriasis. So, it's always very interesting for me to ask them how their like articular or arthritis symptoms have responded with those drugs. And a lot of the time you'll get some interesting answers. And I guess it's also important to be mindful that, if your patient is on methalazine, which, is very similar in action to sulfasalazine, for example, or if they're on PRED or if they're on, etanercept or whatever it is, that they may not come in with their bond or AxSpA or peripheral SpA symptoms because they're already on immunosuppression. So,
yeah, they're already being managed. Yeah.
So it can be quite complex. And I think it's like we said before in our discussions, is if there's enough to make you sit back and think and consider, then it's probably best to refer. And that's what the kind of nice kind of AxSpA algorithm suggests, isn't it? Is that if a patient is younger than 40 and they have 2 or more kind of features of AxSpA, then you should be referring, isn't it? So I think too many times we see these patients are held in primary care because they have a normal CRP or a normal X-ray, and that's not the right way to manage these patients.
Yeah. I had a conversation with a friend who started a FCP role, and he was saying, this is off topic, but he was saying about he had a patient we thought he probably had peripheral SpA related to his he had colitis, I think, but to get into rheumatology you have to have an anti-CCP. And I was like, well, that's not going to be any use for this. But that's the admissions criteria or referral criteria. So I think it's really, that's where I always teach physios that if they have to do blood tests to get people into rheumatology, do them. But actually, otherwise, you're probably better off not doing them, because if they come back negative, the referral can get blocked.
Yeah. I mean, I actually did a couple of teachings for Connect on basically how we can improve the delay to diagnosis, because obviously we have a lot of MSK services around the country. So I think Connect as a whole could really make a big difference in improving the delay to diagnosis. And it's really sad how all of the kind of fast track EIA pathways for rheumatology-based referrals are so heavily weighted for rheumatoid, and they don't accommodate for AxSpA or peripheral SpA patients, because how many of these patients actually come in with a true swollen joint? It's very rare that you're going to see a axpar or a peripheral spar patient coming in with an angry swollen knee. They've generally just got low-grade arthralgia with inflammatory features, and they're not going to have abnormal bloods. They're not going to have erosions on conventional radiograph in early stages. So often these chaps are waiting, 24 weeks to see a rheumatologist. And I think the effects on the person personally, in terms of their personal health, their mental health, and on the taxpayer as well, is profound. Like, we need to do better for these patients.
Yeah, I remember when, because I was sort of around in working in rheumatology back in 2011, and they were just rolling out. I think it was 2000. It might have been 2012. I might be misremembering my dates, but they were rolling out the starts of those EIA referrals, treat to target, those kind of things in England. And I think there was, at that time, there was such a drive to get the rheumatoid patients on drugs early because it showed such a difference. That the SPA patients were totally just missed out, because I think historically they were like, oh, you just x-ray their sacroiliac joints. If they've got fusion, then they've got ankylosing spondylitis. And then it's sort of like, it's turned up more and more and more complicated over time, and the clinics have never kept up. So it would be, I don't know what's going on these days with trying to get those patients in earlier, but like you said, I think primary, it goes through the chain, doesn't it? Primary care, we've got to recognize, we've got to get one, the patients have got to attend a clinician, because if they don't attend a clinician, then we don't know that they exist. Yeah, and I don't know. I suppose when you look at the difference, like you said, when you look at the differences between a rheumatoid patient and an axpar patient, you have, like, you start off with NSAIDs, don't you, with axpar, and then it's like, oh, they're not working. You've got to get the big guns out with anti-TNF. There's no real middle ground. So I think, I don't know whether it is just more difficult to set a clinic up for those patients. I mean, there's no reason why they can't be diagnosed earlier. And you've got to make the assumption that actually, well, you don't have to make the assumption, the data's there, that actually if they start on anti-inflammatories regularly and early enough, then some of them won't ever progress to an anti-TNF. So like you said, for regards to the taxpayer, if we can get those patients into the rheumatologists earlier, then they can get cracking with treatment and management, and also with their general health stuff as well. Like you said, if they're languishing on a waiting list and getting depressed and overweight and all these kind of things, we know that that's rubbish for their outcomes as well. So I think everything just gets better if we can speed the referrals up.
Yeah, that's true. I mean, I think in the kind of parliamentary review they were doing about this delay to diagnosis, is only 21% of trusts had specific inflammatory back pain pathway, which is really, considering that axpar is more prevalent than kind of MS or Parkinson's even, and how many resources does the NHS dedicate to MS and Parkinson's disease versus axpar. It's really sad to see those stats. And I think personally that there's no reason why your first point of contact in terms of your inflammatory back pain pathway can't be physio-led. So you know, it could be completely physio-led in terms of doing the workup, advising on the NSAIDs, and most importantly, getting patients exercising. There's so many good talks at EULAR this year showing the significant decrease in disease activity and inflammatory cytokines just with exercise. So we can make a massive difference to our patients if we just get them doing exercise. And it doesn't have to be the kind of NAS intense stretching every day. It can be anything, you know, any kind of exercise has been shown to be beneficial.
Yeah,
so
definitely.
I know there's a massive shortage of rheumatologists and capacity in secondary care. So that's a sphere where I think physios really need to step into, and we need to be setting up and running inflammatory back pain pathways, and you know, getting the patients who continue to have active disease in a position where they've had a good workup and they can be fast tracked to secondary care for biologic workup. And that process can happen, within 2 to 3 months, really, from GP to inflammatory back pain pathway to sitting in front of a consultant rheumatologist ready for anti-TNF, instead of making people wait 9 years,
Yeah,
So,
definitely. And I think it works both ways as well, doesn't it? Because you've obviously then, with these inflammatory back pain pathways, we obviously know that there's going to be a number of patients that are not going to have axSpA. I mean, it shows it in this study that we were talking about. So you don't want those patients in front of rheumatologists. The number of times that, or when I'm working with the rheumatologists and they just sort of bounce someone out with stenosis or disc bulge related or whatever type problems, and you look at the referral and you know that it's not an axSpA just from reading it, but they're ending up and not wasting the rheumatologist's time, but they could be used more effectively, and that's what they've done with the RA pathways that we were talking about. But they're not doing it with, and like you said, I suspect there are sort of locations in the UK which are doing this brilliantly, and it should be rolled out more across. But certainly with the physiotherapists, like you said, I think it's a perfect. I mean, we see so much back pain anyway. I think we're just perfect to fit into those molds, and save all sorts of time and money and help patients really.
Yeah. I mean, and there's always an inflammatory component to a mechanical problem, isn't there? Like, that's why we inject a degenerative joint with steroid, and it helps because there is always an inflammatory component. So your chap with degenerative back pain, he's always going to have some stiffness in the morning. And yeah, if you give him industrial doses of naproxen, he's going to feel better, isn't he? Because there's always going to be some inflammatory component. So it's, as we said before, it's a lot more complex than just putting it in simple terms. But yeah, I think if we as physios and other primary MSK providers work according to the NICE framework and screen for those extra-articular features in young patients under 40 with kind of inflammatory back pain, and if we work according to the ASAS diagnostic criteria, then we're going to be getting more hits than misses. And we can confidently say, if we use those two frameworks, that this patient's very unlikely to have axSpA, and we don't need to refer them to secondary care rheumatology, because unfortunately, I mean, even if you look at the EIA audit from BSR, like more than 40% of patients in EIA clinics have EIA. So what are they doing there? How did they get there? So it's not, as you said, it's not wasting time, but the sad reality is that someone is sitting at home with 4 very painful swollen joints, getting erosions, or, because of inappropriate patients being referred into these clinics. So there's a lot of things we can do to do better, isn't it?
Definitely. We'll have to get, I don't know, who would it be? The NHS. We'll get the NHS on the phone and we'll lay it out to them. Mind you, like you said, you guys at Connect seem to be doing some decent work in that direction. So hopefully, if that can be used like anywhere as models, and we need to get, I say we, but they need to use the locations which are doing it well, and get others to follow suit. And I think it's like with anything, isn't it? You can easily show, if you could get, like you said, if you could get from 40% to 80%, you would save so much money, both in the short term and the long term, that it's a no-brainer, really. So I think these things do need to be rolled out. But like we said before, it works all down the chain as well. So us guys in primary care, the FCPs, as they roll out in GP land, they've got to be on the ball with knowing who to refer appropriately, who not to. And like you said, it's just as bad to refer someone inappropriately as it is to not refer them, because if you don't refer them, they come back in 3 months with erosions, then they're completely screwed. So we need to be working it both ways, really, and make sure we are referring as well as then not referring inappropriately.
Yeah, exactly. So I guess the key is going to be to improving the screening and kind of procedures and processes in primary care. And probably in the next 5 to 10 years, most of these patients that are presenting in primary care are going to be seeing an FCP, not a GP. So as a physio community and providers of FCP services, it's really the ethical responsibility, I would say, of the providers to ensure that their practitioners are really clued up on screening for axSpA and peripheral SpA, to kind of make the whole journey better for the patient and the taxpayer, really.
Definitely, yeah, definitely. Well, I am going to need to go in a minute, so a good solid conversation. We'll need to have more of these, and we'll try and do them semi-regularly, shall we? Yeah, enjoyed it, and I think hopefully people will learn a little bit from it, but also take some ideas about how they can be better in clinic as well.
Cool, Jack. It's always a pleasure chatting with you.
All right, we'll pick an easy topic next time, shall we?
Okay.
All right, mate. Have a good rest of the day. I know it's your day off, isn't it?
Cheers, Jack. Yeah.
All right, mate.
Bye.
See ya.